Hello friends, this is a case of 30-year-old girl who came to us seeking fertility treatment. On ultrasound, there were bilateral endometriomas and we saw a lot of para-ovarian cystic lesions which according to us were the peritoneal inclusion cysts. So we did a MRI. MRI showed bowel to be adherent to the POD and bilateral endometriotic cysts. So this is the laparoscopy. First step that remains is to separate and dissect the bowel from the left lateral pelvic wall, the sigmoid colon. This will ensure that the bowel goes up well and it does not keep on falling into the pelvic cavity and the POD remains clean. I use a bipolar shearers for this particular job and it works very well. The advantage of shearer is precise cutting along with coagulating, and more importantly it can be used multiple times and the cost is significantly lower. I've been using it since almost 10 years now with absolutely no problems and excellent cutting capabilities. As we see that after separating the bowel from the lateral pelvic wall, we go to the region of the left tube and the ovary where we find the natural windows through which we do a blunt dissection and separate. When the left ovary was separated, we can see hemorrhagic blackish chocolate brown fluid coming out, and that was separated and the ovary was retained in its normal position. This tube and ovary were stuck to each other and to the lateral pelvic wall. Along with the tube, also the ovary which got stuck badly, there were peritoneal adhesions as noted in this particular frame. So we did adhesiolysis and tried to get the tube in the normal position. These are the peritoneal inclusion cysts that we detected on ultrasound. As you can see, this looks like a bunch of grapes, and in a woman with endometriosis there will be classical picture on ultrasound. Whenever this picture is there, be sure that it is going to be minimum stage 3 to stage 4 endometriosis. So these are just held with a grasper and we drain off the fluid to make it easier to handle, and after that these cysts are just dissected out and cut with the bipolar shearers. Just care needs to be taken that these cysts can be adherent to the tube and the ovary, as you can see in this particular scenario, and the tube needs to be dissected out separately while dissecting this peritoneal inclusion cysts. These are completely almost avascular spaces, so with just a bipolar shearer we are able to do that. Now we go back to the left side where we are trying to dissect the ureter. So lateral pelvic wall dissection starts right near the pelvic brim. The assistant here, in this case I was ably assisted by my general surgeon friend Dr. Hemant Patil, who himself is a very accomplished laparoscopic and a general surgeon. So as you can see, we are dissecting with blunt and sharp dissections. Here we are trying to just dissect the bowel more, and with the bowel grasper and with the bipolar shearer, with simple strokes we will be seeing the ureter shortly. Whenever we are doing the dissection, we will find that there is a layer of peritoneal tissue on the top which covers it. So once that is removed, that is when we are entering into the broad ligament spaces, the lateral pelvic wall spaces. Here with simple dissection, as you can see, it's a completely avascular plane, and there, that's our friend the ureter. We will now be dissecting the ureter from the lateral pelvic wall so that when we go to the left ovary, we have the ureter mapped out and we do not have any surprises. As I mentioned previously, she is a 30-year-old girl who's seeking fertility treatment. So we will be doing a fertility preserving surgery. After the ureter is mapped out, we now come to the region of the pararectal spaces, and with dissection we will get the nice pararectal space between the infundibulopelvic ligament and the rectum. There, with just a simple bowel grasper and a bipolar shearers, we are creating this pararectal space. It is again a avascular plane, provided we are in the right plane. Planes have to be understood, and we go right up to the POD in the left pararectal space. This will help to push the bowel medially and also create a space wherein the bowel will also go down, and these adhesions, these are again completely devoid of the bowel. So then once the bowel is dissected medially, it also falls down, and these adhesions can be cut with the bipolar shearer. As you can see, this is what we are doing. We are cutting the adhesions with the bipolar shearer, and if it is done in the right plane, again the dissection and the separation is almost bloodless. The tube and the ovary are coming in the way because of their adhesions, so that is one thing that we need to keep in mind, that the tube and the ovary should not be damaged. Here these are the final adhesions which are noted. So we are keeping the bowel grasper between the adhesions and the shearers, thereby acting as a safety mechanism to prevent any untoward or unintended damage to the bowel. Similarly, what we did on the left side, we will now be doing it on the right side as well of the patient. These adhesions which are there, that will be dissected with bipolar shearers, and the anatomy we will attempt to restore it. We need to keep in mind to have a fantastic assistance, to have a good camera system which gives a good image, thereby having minimal complications during the surgery. As you can see, these are the adhesions of the pararectal adhesions to the POD that we are dissecting out, and they are put in the normal anatomical position. With just a short burst, a microsecond burst of energy, in case there is bleeding, it is controlled. Here on the left side, again we start from the pelvic rim, and the ureter was seen very lateral, because this side was relatively uninvolved. So the dissection starts from the sacral promontory pararectally. With the bipolar shearers, we go right up to the posterior surface of the uterus into the POD. Again, small bleeding is there with just a short current that is controlled, and bleeding is stopped. Now here the role of the assistants comes very important. As you can see, he is helping me do the blunt dissection on the other side and creating a space between the bowel and the lateral pelvic wall. This also ensures that the ureter goes laterally, it goes out of the way, and we get a relatively safe space for dissection without causing any unintended damage to the bowel. Here, as we see, we've now reached the POD space. A nice space has been created. With bipolar shearers, we will be cutting off these final adhesions, and as we did it on the left side, the bowel grasper is used to create the space between the bowel and the posterior surface of the uterus and the POD. Care needs to be taken to ensure that the field of vision is clean of blood and smoke. So time to time the assisting sister has to see that once the gas is there in the field of vision, she needs to open the exhaust of the 5 telescope, with which the gas which is there that gets out and the field of vision becomes very clear. I am using a Karl Storz Image One Spice Full HD camera. I do not use a 3D camera. This entire surgery has been done on a 2D camera, and for the sake of reducing the time of the video, this video has been recorded in 2x speed so that people can go through the video. In case you find any of the steps very fast, maybe you can reduce the speed of the video, thereby you can understand what exact steps are done. Now here, as you can see, the bowel is completely gone down. The POD is nicely seen, the denonevelous fascia is dissected well, and the bowel is completely out of the picture, out of the POD into its normal position. Here whatever smaller fibrosis that is there, that also we are dissecting it and pushing it into the normal position, thereby ensuring that the POD is nice and clean. And this girl, she had severe dyspareunia, severe menorrhagia. I am I am editing this video almost 1.5 months after the surgery. I was awaiting her periods to come. She came to us recently saying that for the first time her periods were absolutely normal. She had no pain during the periods. Her menorrhagia was also completely settled, and they had also been had sexual intercourse, and she was completely pain free during that as well. So as you can realize that the quality of life has improved amazingly to absolutely normal after such a well done endometriosis surgery. This is a stage 4 endometriosis. There is no role of any oral medication. A lot of people will be putting these girls on oral contraceptive pills, or there is a new medicine called Dynogest. In the Western countries, there is a drug called elagolix, but in such severe cases, surgery is what is needed. As you can see, these are the peritoneal inclusion cysts which are there on the left side as well, though they are not as florid as there on the right side, but it has been our effort to remove that as well, because these also have foci of endometriosis. Then we made the tubo-ovarian anatomy normal. As I mentioned, she is for fertility. And after doing that with simple bipolar shearers and blunt and sharp dissection, we check for the patency of the fallopian tubes. Here, as you can see, there are again small peritoneal inclusion cysts. These are very slippery. You have to hold them well and then just cut it off with the bipolar shearers. And all these cystic structures, we try to remove that from the POD, from the surface of the uterus, from the tubo-ovarian masses. Now, as you can see, we are restoring the tubo-ovarian relationship, the tubal anatomy on the right side as well. Here again there were the peritoneal covering, so that has been removed, thereby ensuring that the ovarian surface remains clean and normal, so that when she actually has an ovulation, the egg has a higher chance to go into the fallopian tube. Here, after seeing the overall dissection done, we checked for the hemostasis, and as you can see, till now we've not even used the suction. There was hardly 5 to 10 ml blood loss during the entire thing, and now we will be attempting to see for the patency of the fallopian tubes. What do you all feel? Will these tubes be open or will not be open? Will she be having a blockage or will she be having the fallopian tubes open? These are again the peritoneal coverings which has happened over the fundus of the uterus. This was also detected on MRI, and we are removing them as well, so to ensure that from pathology we convert to anatomy to the best of the possibilities. Here again there are certain peritoneal coverings over the ovary, there it also goes out. And now after having an almost perfect restoration, we will just be taking care of small oozers with just a micro burst of a bipolar cautery. After satisfying ourselves that yes, the hemostasis was well achieved, now what the associate would be doing is to put a Colvin's cannula into the cervix and push methylene blue dye. Again there were certain adhesions between the tube and the ovary. These were also removed. As you can see now, the tube and the ovary is normal. The dye has been inserted through the vagina, and that is a free spill of dye on one side and again on the second side. So it was so surprising and it was so satisfying that after such a well done surgery, we have nice patent tubes in this particular woman. Yes, there is tubal edema, that is because of endometriosis. What we have done is we've given her a course of GnRH agonist depot that will help reduce the edema, that will help reduce the microscopic deposits in the pelvis. The left ovary, there was a gap after removing the cyst. So what we have done is we have just taken a stitch with 10 Vicryl to ensure that the ovary becomes full once again. Once that is done, the ovary heals very well, and it has been our experience that when we have done AMH levels in these girls, don't do it immediately post-op. It takes for the ovary around 3 to 6 months for recovery to occur. So what I like to do is to give these girls a course of DHEA along with folic acid in the post-op period, and after 2 doses to 3 doses of GnRH agonist depot. Since the tubes are open, they are asked to be together, and we found that even stage 3 endometriosis after such a well done surgery, the girls have conceived spontaneously. There now we are taking the final few stitches on the ovary and approximating the surface of the ovary to ensure that it heals up very nicely. It can be a bit tricky to suture this ovary because it is cut in various places because of endometriosis. So this is where the suturing skill comes into use, and if you've done it well, once you scan this ovary after 3 months, you will find that there are actually follicles and it looks like a proper ovary on ultrasound. There we just cut the sutures, and after that I have a habit of giving a good saline irrigation. I use up to 1 to 2 liters of saline. I like to get all the blood clots out of the pelvis, and what we have found that once we do this, the post-operative analgesic requirement reduces, post-operative pain is much lesser, and of course when the patients, we've done C-sections on these girls, the POD is almost clean. There after a good wash you can see there is hardly any bleeding. The total blood loss in this surgery was hardly any 10 ml. And thank you so much for watching this video.